Ladies and gentlemen, thank you for standing by. Welcome to the Disability Competent Care Webinar Roundtable Series. At this time, all participants are in listen-only mode. Later, we'll conduct a question and answer session. Should you require assistance on today's call, or if you'd like to ask a question, please press star, then 0. Now I'd like to turn the conference over to your host, Mr. Chris Duff. Go ahead, please.
On behalf of the Lewin Group, I would like to welcome everyone to the 6th 2014 Webinar Roundtable session, this one focusing on home modification. As Jeff stated, my name is Chris Duff, and I'm a Disability Policy and Practice Consultant. Under contract with the Medicare and Medicaid Coordination Office at the Centers for Medicare and Medicaid Services, the Lewin Group has engaged myself and a few colleagues to provide technical assistance to providers working with adults with disabilities. First of all, I'd like to introduce you to our platform for this presentation. If your slides are not advancing, please push F5 on your computer keyboard. Also, please note the 2 icons circled at the bottom of the screen. The green icon of a file folder, third from the right, provides you access to resources for this presentation. The center icon with the CC will enable closed captioning. The brown icon, fourth from the left, will open a chat window for participants to pose and discuss any topic-related questions to other participants and speakers. After the brief presentation, we will also open the phone line for participants to ask questions directly to the presenter. As stated earlier, this is the 6th Webinar Roundtable session in this current series. The last 2 will be presented on the next 2 Tuesdays at this time, concluding on April 8th. Last year, we published a comprehensive disability competent care self-assessment tool describing disability competent care in 3 key components: individualized care coordination provided by an interdisciplinary care team, redesigned primary care delivery, and flexible long-term services and supports. We followed this up with 9 webinars focusing on individual components of disability competent care. All of the webinars are recorded and available along with PDFs of the slides at the link at the bottom of this current slide. Our goal in this series is to be highly practical, using experts in each topic area with organizational examples or first-person stories to demonstrate key messages. The presentation will be no more than 30 minutes, allowing the remainder of time to explore questions or issues submitted by the participants. The chat feature is available to participants throughout the webinar. Beyond the chat feature and the open phone line, we will be using instant polling to ask specific questions to help guide our presentation. To demonstrate this process, here's the first polling question for today. Is your plan or organization responsible for home assessments and or modifications for your participants? If you could choose one of the answers and push submit, I will review the results in just a minute. Today we are exploring disability competent practices related to the value of home modification. Our goal is to prepare providers, be them health plans or healthcare providers, to support their participants' ability to live in their setting of choice and to maximize their functional independence. The presenters will discuss the importance of home assessments and the imperative to involve participants and their key caregivers in the process. When a person acquires disability, defined as a functional limitation, or loses ability due to illness or aging, their ability to safely function in their own home may be threatened. It is important that care coordinators continually monitor the needs and well-being of their participants in a manner comparable to how they monitor the individual's emotional and physical health. The need for modifications is to be judged not only in terms of meeting functional needs, but also in terms of prevention of injury or progression of dependence, and potentially minimize the need for assistance from others. By modifications, we mean everything from non-skid surfaces under a throw rug to grab bars and reachers, all the way through ramps and structural modifications to enable independence in activities of daily living. Decisions regarding home modifications require clear policies and procedures with inherent flexibility to modify as required for the unique situation. Jesse, could we go back and review the polling results from the first question? I see that the majority of you are not currently responsible for providing those home modifications or assessments. I'm glad that you're still interested in the subject. I think as more and more providers and plans assume responsibility for the whole continuum of services, including waivers, it's important that everyone, regardless of whether you're directly responsible or not, become familiar with the opportunity and process for assessments and modifications. Why don't we do one more question, if we could, on to the second polling question, and then I'll hand it over to speakers. The second polling question is, how does your organization identify a participant's need for a home assessment or modification? And even if you aren't responsible for doing them, if you could at least state how you would identify the individual's need for this. While you're answering that, I'll go on to introduce the speakers. Today's webinar will be presented by Brian McCarthy, a certified aging-in-place specialist and home modification contractor. Having lived with a disability since birth, Brian understands the importance and value of design to maximize functional independence. He conducts home assessments and manages modifications from design and development through remodeling, specializing in work with elderly and disabled homeowners. He has experience working with counties and health plans in Minnesota and home modifications funded through home and community-based waiver programs. He will be joined by Mary Larson, who brings over 30 years' experience in the field of occupational therapy. Much of her experience has been working with clients in their home and community settings, seeing firsthand how disability affects safety and independence in activities. She brings a passion for identifying barriers to an individual's ability to participate in their life. Through an assessment process, she recommends services, equipment, and environmental modifications to increase the individual's ability to participate in life activities and improve their safety. With Brian bringing the design and structural expertise and Mary the rehabilitation expertise, they together comprise the breadth of knowledge and experience necessary for most any home modification need. Now I'll hand it over to Brian, who will review the second polling question and start his presentation, and then Mary will follow his presentation. Brian.
Thank you, Chris. I'm happy to be here. I appreciate the opportunity to be involved in this webinar. I should give you a quick background that brought me into this business. I was a home builder for 15 years over the housing boom. And when the market changed in 2008, I needed to adapt my business to fit the current economy. As a person with cerebral palsy, I thought there could be an understandable fit for me to get involved with home modification for people with special needs. I not only understand the physical structure of a home, but I possibly have a unique understanding of how people live in their homes with physical limitations. My speed is very mild to most, but I do need to concentrate on issues that other people might not see. For instance, I plan my approaches to steps or staircases. I take mental notes on the direction of the door swing. I plan ahead for handholds, keep my balance. These are all little things that I can easily share in conducting an assessment. So that will go to slide number 8. Real quick, looking at the polling results. I guess I missed that screen, but slide number 8. There are 6 parts that we've identified in what we want to address in this presentation. We want to identify the need. We want to identify the need, so we want to know what's new for the participant. It could be a new home, a new challenge in their abilities, we got to figure out what we're trying to accomplish in identifying the needs. So once we identify the needs, then we need to make a referral for assessment. Now, who makes the referral? Does the participant? Does the family? Most referrals are made through by the healthcare providers. So now we're on conducting assessment. We need to get the background information. Conducting the assessment is kind of the funnest part of my job. I have the chance to meet the client, see where they live, see how they can move around their home. And at this point, you're just gathering all the facts you can. You're figuring out strong arms or weak arms or anything that might help you in the conducting the assessment. Once we've done the assessment, we need to put things on paper or go to modification recommendations. In doing these, we need to gather all the input from everybody, from caregivers to PCAs to family members. And also in making the recommendations here, we need to understand the financial limitations. Some people have waivers, some people have health plans that pay for these. A lot of them are private pay. So we've got to be cognitive of how much, how the money is going to come in and what we can spend it on. Once we have the plan on paper, we need to implement the recommendations. We got to make it work. We got to follow through the process. You know, we got to oversee the project. And who oversees the project? A lot of times in my business, I occasionally see the project stall out where the care coordinator or the case manager doesn't follow through on, moving the process along. So once the ball is in place, we got to move forward. Number 6, once the modification is complete, we need to orientate the user to the modification. This is also part that we forget about a lot, but it's very important. Once we've done a home modification, maybe a bathroom modification, it's good to take the client in for a dry run. Show them why we put a grab bar in this location, or show them why we've put a paddle switch for a light versus a toggle switch for a light. We just need to show the client all what we've done to help their home environment. So moving on to slide number 9, identifying the needs. As the healthcare provider or care manager, you need to identify the needs for a home modification. With our busy schedule and our many clients, you don't always have the luxury in doing a weekly home visit. So be aware of little things that might trigger a need for a home modification. For example, you need to think of a participant that might have a declining physical abilities. For example, I have elderly clients. 1 year I'll do a grab bar. The following year I'll do a ADA taller toilet. The next year it's a removing the tub and putting in a walk-in shower. So just be aware that if you age or the condition worsens, that there's a need for identifying the modification. You might also need to ask questions as a provider. How's your new apartment working out? Are you able to get into the new bathroom? People move, people change locations, so you got to be aware that the need might arise with that kind of stuff. Also be aware that when people get new products, such as a new wheelchair, don't assume that it will fit like the old wheelchair. Some wheelchairs, as we all know, are longer, taller, wider. so they might not make the curve in the hallway to get around into the bathroom quite as well. So just be aware if your client does get a new product that you might need to do a modification to make sure it works for him. Here's another example why they might need a modification. Not all modifications are meant for the recipients. For instance, sometimes we need to understand the limitations of a caregiver. Do we expect a 52-year-old mom to be lifting a 165-pound child? We might need to plan ahead before the mother's back is out. So a lot of the modifications are with the caregiver involved. Why do we do this? Why do we do these modifications? Mainly slips and falls, the safety of living in a home alone. The next one is important to me is maximizing the function of an individual. Let people live their full potential. It's kind of the right thing to do. I have an example that always hits me in the heart. I had a client that had a 2-bedroom house or 2-bedroom condo with heavy shade carpeting, and he had a wheelchair where he had a hard time pushing it around. The modification that I did that was so small that helped him tremendously was incredible. He lived there for 15 years without the ability to get into either one of his bedrooms. So he had his bed out in the main family room. And by removing the shade carpeting and putting in a linoleum floor, then he had the chance to glide around in his chair. So once he could make it move around in his chair and in his bedrooms, his home environment just became so much better for him. So I'm going to move on to, I guess we do one more thing down here. We always need to be realistic about the cost of a modification. Most modifications are relatively inexpensive. A lot of modifications are just a taller toilet and a few grab bars. But as a healthcare provider, we need to understand the limitations of what we can really do to be cost effective. I'm going to move on to slide 10, the referral for an assignment. As a healthcare provider, we need to identify the goals in planning for the assessment. We need to be specific in what we need to get accomplished. For example, many times the primary goal is to get the participant out of the hospital. So you need to come up with so do they need to come home? Do we need to get a wheelchair ramp? This would be the primary goal. Do they need a bed on the main floor? Once again, this could be a primary goal. But doing the assessment, you got to look ahead and it be a secondary goal. In this situation, it might be a functioning bathroom with an ADA toilet and a rolling shower. And then once again, you got to look ahead and maybe look for a long-term goal, which might be converting a space in the main floor for use as a bedroom, or moving the laundry facilities out of the basement to the main floor as well. This could be a 3-year plan. Sometimes the plan is limited, so you realize everything doesn't need to be completed all at once. Actually, it's very common that you make a plan and you do the modifications over, 3-5-year period. I see that all the time. As a healthcare provider, you may have the skills and knowledge to do assessments on your own. Most modifications are quite simple. As I said, it need a a couple of grab bars, and that's all they need. But at times, you need to understand that we need a professional advice in a larger project, and the need to use professionals, such as an occupational therapist or a physical therapist. It might even involve a contractor that has structural knowledge. So we prepare to think through some of the concerns before the actual assessment. Conducting the assessment. Once I get a referral from a care manager to do the assessment, I start gathering the facts. Most referrals come to me through an email. Obviously, I get the recipient's name, address, phone numbers. I also have the agency's names, contact person, and their phone numbers as well. Hopefully, the referring agency has attached some of the background information that we've discussed. What are we trying to accomplish? What are our goals? What are the challenges? How is the project going to be funded? And then it's out to see the client. And Mary Larson, you could move ahead at this point.
Yes, that's usually I do come in at this point, and this is when I'm trying to find someone to work with on the remodel and all of that. So, did you have anything else on slide 12, or should I move on to slide 13?
No, you can go ahead, 13, yeah.
Okay, all right. It's been my experience that whenever possible, it's ideal for an occupational therapist to meet the participant in their home setting to identify what their needs and priorities are. If this isn't possible, the participant needs to be seen like in the clinic setting. I think it's important to have videos or photos of their home environment, preferably with the participant demonstrating in the videos their barriers and abilities. So how do they do the transfer in the bathroom, and what are the challenges while they're doing it? And of course, I think a full assessment is needed to be completed. I like to look at how the individual can use what function they have to the best of their abilities. Sometimes it can be if somebody is maybe quadriplegic and they only have movement in their thumb, and might be looking at what could they do with that thumb. Can they operate a switch to answer their phone or to call for help from an attendant? So I think there's all levels of abilities, and we want to try and promote as much as we can from the client. I think being aware of how variable abilities are along with the progression of a disease is important to consider. Today might be a good day, and a piece of equipment or modification might work. I like to observe or at least discuss what a bad day for them is like, so we can problem solve changes in the setup that might need to take place on those bad days. I think a strong knowledge of available products and which piece of equipment fits the needs of the client is important as well. Often the mistakes I've seen is when a great piece of equipment is ordered or a nice modification is made, but it doesn't fit or work for the participant. For example, a wonderful bath bench has been ordered, and it may be too big for the participant's bathroom, or it might be assembled incorrectly with the arm rail on the wrong side of the bath bench. A raised toilet seat might be ordered, but it doesn't fit their toilet. Moving on to slide 14, when I first meet with a client, I do like to assess the full living space. And while my primary focus may be seeing the areas the participant has identified as problem areas, I may see other things or make other recommendations to improve functional abilities in other areas of the home. It's possible that I may identify an area that the participant just assumed they could never improve their safety or independence in. They may be unaware that there is a solution out there to help them. I also like to review their daily routine and which tasks are most difficult. oftentimes it's breaking the task down and asking them about each step of it and where does the problem begin. I like to ask them, where are your biggest barriers, challenges, and frustrations? Sometimes there are low-cost solutions that can be trialed prior to a remodel project. I like to borrow from an equipment loan program whenever possible. Sometimes I've worked a lot with a medical supply company, and they may be willing to borrow me a piece of equipment to trial during a session, or send a representative from the medical supply company if it's a complex or expensive piece of equipment. It's also nice to meet out there the people who may be installing the ramp, just to be there as a representative also for the client or the participant, so that you, especially if there's difficulty with communication or memory, vision, any of those deficits, so that I can help guide the participant or bring up topics I know they were interested in. I think that we always want to consider the amount of work that needs to be done to make the environment functional, and it's a good topic to discuss with the participant. Sometimes I like to introduce other options just to make sure this is really where they want to stay long term, so bringing up the options of moving to another home, to an assisted living, to a more accessible apartment that may better meet their needs. Certainly when you're going to do remodeling, you want it to be a long-term project. So at this point, I'm going to hand it off to Brian, and he will be discussing step 4, modification, recommendations, and plans.
So once we've had a chance to meet with the client and visit the house, we should begin to have enough knowledge to start putting something down, our recommendation down on paper. This plan might also be referred to as the assessment or the project scope or the proposal. Anyways, we need to get specifics down on paper before we finalize a recommendation. Yeah, but it's however prudent to discuss with family members that this plan is a workable plan. Let the caregiver see the plan, get their input. Have the referring agency offer their recommendations. There might be financial limitations that you need to consider. So once the assessment is complete, most healthcare providers get 2 or 3 bids on the cost of the project. Also be aware that there might be multiple funding sources to complete the project. And don't forget you can complete a large modification plan over a few years. So Mary, do you want to finish it up?
Yep, thanks, Brian. On slide 16, it's been my experience that a successful project involves teamwork. I think Brian alluded to this earlier in the presentation, but I like to prioritize also the list of challenges and barriers with the participant. I like to make sure the participant is fully aware of all aspects of the final plan. I also like to make sure they are comfortable with the plan and that they believe it fits their needs. I feel like at times projects are unsuccessful when we don't have total buy-in from not only the client or the participant, but also the caregivers. I try to clarify with the participants that this project will be done in phases, that this is a process. It is possible that once the project is completed, they may need training to successfully utilize pieces of equipment or to access the environment properly. And as far as setting expectations for the project, I think it's important to explain or describe what to expect as a time frame, talk about what it will be like with construction is underway. Will there be talk about the noise and the dust and the number of people coming in and out of the home. I also like to educate the participant on what the outcome might be and any limitations that may still exist or need to be addressed. Available funding and costs may guide the route the participant takes. They may need to prioritize and choose one area of the home to remodel or to improve accessibility, and then choose lower cost items to improve accessibility in another area until more funds are available. For example, Brian talked about someone coming home from the hospital and they need a ramp, and they need a ramp to be able to get in and out of their home, and that's a safety issue. And maybe they also need their bathroom remodeled. But the participant may be willing to do simple, low-cost changes in the bathroom for safety reasons, and then choose to go with the ramps, which is going to be a little bit more of an out-of-pocket expense. I think it can be tough to manage your life during construction. Whenever possible, it might be best to look into another place to stay, or at least go out as much as possible during the day when construction is taking place. On slide 17, this slide has a list of possible modifications a participant might be considering: ramps, accessible doorways, grab bars, etc. As you look at this list, you might notice that all of the modifications address physical barriers. Physical barriers are often the easiest to identify, but it's important to keep in mind cognitive and visual impairments as well. Will this person have the ability to learn or remember how to use this modification? Will they be able to see all the features of the modification and use properly? Might they need training to learn how to use the modification? Should we consider a visual strategy such as use of contrast to define work areas and improve the ability to see? For example, if a microwave was being chosen during a kitchen remodel, consider vision issues and look at the use of contrast. Don't choose a white microwave with white buttons. Also consider culture. I think this is really important. And will the home modification interfere with any cultural beliefs? And I had an example of that I'd like to share. I actually saw a woman that had 2 different raised toilet seats in her apartment, and neither one of them were being used. And it had to do with her accessibility for cleansing herself, which was a cultural thing that was done, and she could not do that while using a raised toilet seat. So I think it's just some of those little things that maybe people aren't thinking about, and they're thinking about what's the best model and what's the safest option. On slide 18, as far as orientation of the participant and caregivers to the modifications, again, Brian mentioned this earlier in the presentation a little. I don't think we should assume that the participant or caregiver knows what to do when the project is complete. I think we need to walk through the changes that have been made with the participant and caregivers, have them demonstrate use of that modification or equipment. Sometimes there's more than one caregiver, and make sure that either the one you have trained is going to pass that along or come back when you can connect with another caregiver and do that as well. Bringing the project to completion is really important. So if you've been there and you've shown them how to use it, but you know the person has difficulty with their memory and you're just not 100% confident they're going to remember, refer the person on. Maybe there is a therapist that they see on a regular basis, or a family member that you can train so that they can keep going through the training with them. But remember to refer them on so that they get the support that they need to be successful. Chris, is there anything you'd like to add at this point?
Yeah, I'd just like to thank Brian and Mary for their presentation. It was quite interesting. I'm just going to summarize, and then we can open it up to questions. In summary, modifications can and do make the difference between remaining in one's home or needing to move to a setting that's more restrictive, or perhaps even an institutional setting. So that points to the significance and importance of the assessment and following up with recommendations. To be optimally effective, the care manager, assessor, or home modifier must consistently involve the participant and their caregivers, for they commonly have the best ideas for improvements. While some modifications can be quite involved and expensive, the majority are simple and low cost. When the costs are more than the health plan or provider or individual can support, other sources of assistance and support can be found with some creativity on the part of everyone involved in the process. Now, at this point, Jeff, could you open the phone lines, please?
Ladies and gentlemen, if you'd like to ask a question, please press star, then 0 on your touch-tone phone. You'll hear an acknowledgement tone. An operator will take your name and further instruct you. If you're using a speakerphone, please pick up the handset before pressing the numbers. Once again, if you have a question, please press star, then 0 at this time. One moment, please, for the first question to queue up.
Thank you. Before we move into the open discussion section, I would first like to call your attention to the survey link. We would very much appreciate everyone taking a minute at the end of this session to answer just a few questions to give us feedback so we can better tailor future sessions and written products. Before going to discussion, I'd like to ask one more polling question, and that is, does your organization have a policy to guide staff in regards to funding home modifications? Ultimately, a lot of this will end up coming down to funds and the availability of funds. So if you could give us a sense of how your organization handles that, I'd appreciate it. And while you all are voting, I'm going to jump in here with a question. Brian or Mary, or both, could you give an example of a modification that you worked on that involved multiple funding sources, talking about your role as the assessor and the role of the care manager?
Yeah, Chris, I'm thinking about sometimes some of the examples that Brian brought up where someone's coming home from a hospital and maybe they already have a care manager involved with them who's calling to say, can you go out and assess their home, figure out what they're going to need. They're coming home in a wheelchair. They weren't in a wheelchair before. And I think, again, some of the quick things that maybe they were willing to authorize payment for was the ramp to get into the home, maybe the raised toilet seat. And then sometimes what I like to do is come back, and then the client sometimes identifies additional needs, and at times they've been willing to pay for them. If they've needed a new phone, I've used the TED program, so the telephone assistance program. And then also I had a gentleman recently that was able to get a computer from a local DSW who did some fundraising for him.
Brian, do you have any examples?
No, on my side, the private pay is always struggling to come up with the funds for modification. Some families just don't have, the couple $1,000s that it might take to do what needs to happen. And there's a lot of neighborhood organizations, like the Neighborhood Revitalization Program or the Center for Energy and Environment. That's one funding source by the federal government that very rarely is tapped into. But if you can be able to offer some of these funding ideas to a private fund situation, it's very helpful. So yes, I see it quite often.
I think there's no shortage of creativity here. I note that just a couple days ago, a former client of mine sent me an email, actually a blast email to a lot of people, I'm sure, asking for financial assistance to repair his van. And so I think it's just creativity. It's to look at their lives, look at who's in their lives, look at how they affect the community, and see how you can pull in those people who are in their lives to assist in the process. Let's go back to the polling questions if we could look at the answer. Again, most of you are not currently responsible for those assessments. What I'm really very pleased to see is that those of you who are involved, you do fund some degree of modification, but that your decisions are being made on a case-by-case basis. I think that's very important. As we say throughout this, every component of healthcare, you need to look at the individual, their immediate context in order to make the decision about what's best for them. Most state programs that are able to fund waivers are able to fund home modifications through waivers may have a lifetime limit or an annual limit or whatever. And, of course, you need to live within the limitations of the program you operate within. But also, even within those limitations, you could be creative in terms of prioritization and so on. One example of creativity is a gentleman who I worked with many years ago, and he had progressed to the point where he needed a scooter in order to access the community. The problem is that he didn't want the scooter in his house. So that was kind of difficult. We lived in a northern state, cold most of the year, or good portions of the year. And so we could have put a ramp in the house, in front of the house, and he could have kept the scooter either in the hallway or in his living room or wherever. That wasn't his preference, but that was what was needed. That was fine. Once we sent someone out to the house, it became clear just because of the layout of the house on that plot of land that a ramp would have had to kind of wind around the side of the house and would have been quite expensive. Probably, I think if I remember correctly, in the range of $8,000. Instead, what the consumer suggested, and as we researched it, we proceeded with, is we purchased a shed that was on footers, so it was on the ground, and so therefore it was frost protected. It also was secure, so the scooter would not be stolen, but it was in his yard, and so therefore the scooter did not sit in the middle of his living room. He was able to secure the scooter for his use once outside of home, and that met his needs, and that was best for him. I think that's just an example of how you need to step back and look at individually what works for different individuals. Jeff, did you have someone on the line?
Not at this moment, but
okay.
As a reminder, once again, if you have a question, please press star then 0. If you've already given your name to an operator, then please press star then 1.
Brian, why don't we take one of the questions that was submitted? Can you talk a bit about the different kinds of ramps and from built to temporary to modular, ramps outside doors and garages, whatever? Can you just kind of give a sense of the kinds of range of ramps that people can consider?
Yeah, I sure can, Chris. A lot of times if it's going to be a temporary ramp, under 6 months, let's say, if a homeowner can get by with a metal ramp that they can rent for 6 months in return, that's ideal. However, that's not always the case, and in Minnesota here, the ramps that most of us put up are wood and green-treated lumber that sits on the ground, and they have a process now where ramps don't need to be set in footings, so they don't need to be cemented into the ground. They can kind of, what they say, float on the soil. So we do a lot of wood ramps as well. Also, being here in Minnesota, we try to get ramps into the garages if possible. A lot of times there's only 1 or 2 steps into the service door out of the garage. And if you have a 2-car garage, obviously you're going to give up one of the spaces for the ramp. But on the flip side, if the wind is blowing and the snow is coming down, it's pretty nice to be able to drive the van into the garage, close the door, and have the time to get out of the ramp or get out of the van on the ramp into the house where it's a little more warm or tempered, but the garage door shut. I've also seen people concerned about ramps in the front yard as maybe somebody can look at it as though there's a person in the house with a disability, so they're looking at it could be a chance to break into the house per se. So a lot of times we're trying to hide a lot more of these ramps into the garage just so they're not exposed to the front yard and all the people around.
Thank you, Brian. I appreciate it. We have a question here from Martha from Inland Empire Health Plan. And actually, we've had that from a couple of people. Is how do you handle rental apartments who need modification? And I think it really boils down to a couple things. One is, if the question is the person does not own their own place that's being modified, what are the things you need to consider? And then secondly, if they're going into a shared living setting or assisted living, what is the line between what the individual is responsible for and what is the landlord or owner of that residential setting responsible for? So, Brian, why don't you take a first shot at that, and then Mary, if you could fill in.
Okay.
I've seen it go both ways where, obviously if it's a rental apartment, you need a letter from the landlord stating that you can put a ramp in the front yard or stating that you can put a door opener on the front door. As far as financing goes, I've seen it kind of go both ways where they might split the cost with the landlord. If that doesn't happen, a lot of times the state of the waiver program will pick up the entire cost of the door opener. But, yeah, that's kind of what I know.
Okay. Mary, what's your experience?
My experience has been that usually people want their tenants to be safe, and they don't want them to have injury while they're in their building. And so I just feel like when I have been in a situation where someone lives in assisted living or rental apartment, that if I go down and talk to the building manager and explain, with permission of the participant, of course, but explain what it is we're thinking about and the possibility of it. And then I feel like there's some negotiation that starts to occur between the participant and the building manager, and if there's a care manager involved, and somehow it's worked out and it's decided who's going to pay for what. And certainly, so I had one example where there was someone that did not have a toilet that met ADA requirements, and the building manager was totally took responsibility for changing that out to a higher toilet because he knew that was something that was needing to be done anyway in his building. So that's kind of what I know.
Mary, that's a great example of so much of it is just simply getting engaged with people and seeing how they can help out. It's just doing the ask. And so that's a great example of that flexibility. Maybe you could each answer this question, and that is, do home assessors need to be certified? And if so, what qualification? And I know each of you do some home modification, so if you could each kind of talk about what you know about certification and then about your background.
You want to start, Brian?
Okay. My background, and I guess my only certification that I have is CAPS, Certified Agent in Place. And that's just a certification. It's not a license. But it's a great course to keep updating your knowledge of, different tricks of home modifications. Chris, I kind of forgot the question. Sorry.
Yeah, no, I think what you're saying is there really is no national certification for home assessors. I think some people have, and I think Brian's training that he's gotten that's really focused on aging in place is a thing to look for. Mary, in your work there's OTs and PTs are trained very broadly. Is there any specific training within those disciplines that you think is of particular importance to this subject?
I think that there's a few things. I think that a therapist who is used to working in the home or the community setting is more skilled at really looking at what the person needs and having them demonstrate for them how they're doing it now. When you're in a clinic setting, it's maybe not their education, it's just their experiences in a clinic setting. So they don't have the opportunity to see that person function in their home. So sometimes I feel like experience is good to be looking at. And I certainly feel that if anybody has any extra certifications or experience with vision or cognitive issues, there's assistive technology professionals, which someone can have that certification and be, an OT, a speech therapist. They can be a number of different people, but they are familiar with how to set up assistive technology and home access, that sort of thing. So I think there's a number of different professions out there that do a variety of things, but I don't know that there's any specific certification to home modification.
I think this, if I were not knowing kind of where to start, I would call my local Center for Independent Living or the AAA or the Health and Disability Center, Resource Center in your area. They would have names of people who could help with this and would have some expertise. Similarly, a question came in from Becky about being in a rural setting. How do you find competent and specialized providers to do home modifications? What's important, and I think, Brian, when you look, I know sometimes when you work with waivers, you need to get 3 bids. What do you look for in accepting a bid from a contractor? First of all, how do you find good contractors? And secondly, what do you look for as minimum qualifications for the contractors?
Well, as you know, I'm probably one of the contractors that are bidding on the project, so yes, I'm bidding against the 2 other contractors. Regarding the rural setting, that's tough. You're out in the middle of nowhere. I would just contact your kind of a lead builder in the area that has a good reputation, and you might have to work through the project slowly and thoughtfully and get creative. I think doing home modifications, it's all about creativity and developing the space. It's not a cookie cutter type remodel. It's taking down the floors, removing thresholds. It's kind of a strange remodel, but I just think, you go for the best builder that you can get regarding, being out in the country.
Mary, do you have anything to add on that?
I have had the opportunity this past year to work with a company that actually has a grant in the state of Minnesota, and their mission is to go out and assess people in rural Minnesota and their adapted equipment needs. And that's been really exciting because I've never seen anything like that before. But I know that it's really hard out there to find people who can do that work and then do the training and follow up after.
That's interesting. If people want any further information on that, Mary's email is on one of the latter slides here. You can follow up with her and she can put you in connection with them. I think my only answer to it, my only addition would be to go back to those Centers for Independent Living and AAAs. They're the ones who have their feet on the ground in the community. A lot of this is word of mouth. It's the same thing that we would look for as we're trying to have some work done in our own homes. I think licensed and bonded is certainly something we would look for in any contractor we would work with. I think a similar mindset would be used here. Another question came from Nancy M., and that is an interesting example. Due to expense, I'm aware of stair glides being sold on the internet secondhand. Are you aware whether these are easy to reinstall in another home and whether people have had good luck doing this? First of all, it's a question about stair glides and their ability to apply in a different home. And then secondly, it's about accessing used equipment. Are there major concerns with that?
Chris, I have heard of people doing that, but I don't know if you're buying someone else's problems. Obviously, a stair glide can range in price from 3,000 to 8,000, depending upon the landings and the turns and this kind of stuff. If it's a straight run, that might be workable. But when there's a turn or a landing, most of those stair lifts are manufactured for that exact space down to the eighth of an inch measurements. So they sound nice, and I think you could do it with a straight run, but I think it'd be hard to fit an old one in a house with a angled staircase.
Yeah, I think what Brian is what you're saying, Brian, makes total sense, and of course that would not have crossed my mind. What that points to is I think you would want to find someone who can install it locally, who will help you research the product before you purchase it. Someone with some expertise, whether it's a local supplier of that actual Stair Glide product, or whether it's a contractor such as Brian, who's done installations of Stair Glides. I want to make sure I get an expert before proceeding with the purchase of anything for that purpose.
An interesting point on that is I'm a general contractor. I have a general contractor's license. I have subcontractors that work for me to install lifts because that's a whole separate license. You need an elevator license to install a stair lift, and that's a license that I don't have. So it may be tricky to get a installer that's licensed to put in a used piece of equipment.
That makes sense. That's great. Before I ask the last question, our time's winding up here. So just wanted to take a minute to review the resources we have listed on a ladder slide here. I believe it's slide 24. These are some resources that are readily available to everyone. They are really more along the lines of checklists and so on. First step is just focus on safety, because a lot of the assessments that are being done are first and foremost the focus of safety. That's like step one of home modification. So these are some references. One of these in particular is really quite long and involved, but by at least going through it, you'll get a sense, and I believe that's the third one there, you'll get a sense of what's involved in doing this kind of work. So I would encourage you to spend some time with those resources. So in closing here, we would like to solicit your opinion on this series as well as past webinars and supplemental resources. Please take the time to complete our survey at the end of the webinar and send us your ideas for future topics and content. Contact information is listed on one of the ladder slides. With that, I'm going to ask one more question that has come in, and that is related to the idea of modifications to meet a unique needs of an individual. Are there situations where client choice about aesthetics is allowed? And this is especially when you're looking at external funding such as a waiver. If so, is the client responsible for any additional cost to get a certain look or style? Or are they limited by just simply what's being recommended by the assessor? Both Brian and Mary, if you could quickly comment on that, I'd appreciate it.
In my situation up here in Minnesota, we have a few of the big box stores that I'm sure that you all have, and my material that I buy, my tile, my paint, my faucets, I just say you can get anything kind of middle of the road and priced accordingly, middle of the road regarding these box stores. However, if I do have a client that wants a fancy tile and tile can go to, $40 a square foot, obviously I would just make the client pay that above me on the waiver. That doesn't happen all that often, but I give my clients a little bit of a leeway to buy what they want. most of my clients will leave me in charge of picking up tiles and faucets, but if they're interested, get involved, yes, they can go and pick it out, and if there's enough charge, we charge accordingly. So.
Thank you.
For me, my feedback would just be if there's something that they need a certain one because of vision or something like that, if there's a justification, I will try and explain it to whoever is paying.
Thanks, Mary. Thank you, Mary and Brian, for your presentation today. We look forward to continuing our work this year to support plans and providers in the needs of people with disabilities. Next week, we'll resume the series. Our topic will be focusing on establishing the relationship between community-based organizations such as Centers for Independent Living and AAAs and health plans. How do you build a partnership between the two? Thanks, everyone, for your attendance today, and we look forward to having you involved next week. Thank you.
That does conclude our conference for today. Thank you for your participation and for using AT&T Executive Teleconference Service. You may now disconnect.